I'll go straight to the presentation. Those are my disclosures. And these are the session objectives. So my task here was very easy and straightforward. And after the previous presentation, it's been made much easier, really, because Professor Berger touched on quite a few points. So we're going to discuss the overlap between TB and COVID, and then compare and contrast them, and of course look at drug-drug interactions with a focus on drug-sensitive TB, but we may touch one or two points with drug-resistant TB, since I noted that was raised up. So before we start, I'm going to need 2 volunteers of a medical background, because this is an interactive session, so the people with the mics, just be ready. So this is our first case scenario. This was taken from one of the patients I saw. So you have a 35-year-old gentleman who has been treated for TB for 4 weeks. Then he comes for his review and says that his cough has been worsening over the last 3 days, his fever has been worsening, and he feels fatigued. His vitals are normal, but of course, you can notice the low BMI, and this is a person who, as one of the evaluations, a COVID test was done, and it turned out positive. So the first thing that I would like to know, and only one volunteer in the interest of time, is which of the following would most accurately describe the interaction between TB and COVID? So is it that there is no interaction between the two? Is it that the COVID will worsen the TB? Is it that the TB will worsen the COVID? Or we need to stop the TB treatment and treat the COVID for a while? So one volunteer. Again, it's an interactive session and there's no right or wrong answer. So I know a few faces here, so I may pick on one if... Okay, so again, she'll forgive me. Dr. Kakusa, just give us your opinion, because we have to move. Yeah, so Dr. Kakusa is a physician, a wonderful physician from Kabwe.
Looking at the clinical picture of patients already having TB, and I already alluded to in the question that they are more predisposed to fibrotic lesions as well as superadded infections. So TB will definitely very likely worsen the COVID-19.
Okay, so we'll ask the same question again after the presentation. We have some nice data that analyze this. Thank you for that attempt. So second volunteer. So after doing your risk-benefit ratio, you decide that you want to treat this patient. So you have 4 treatment options there. Which one will you go for? And like I said, I think Professor Berger's presentation made it quite easy for me, but and Dr. Nyuma Mbewe's presentation as well made it very easy, because I think she looked at the strength of evidence for each of these agents. So a volunteer. I'm only seeing people who are my senior. Oh, there's a hand there. There's a hand. Thank goodness. We can just give the mic there so we hear the answer.
The answer there will be B, since if we use A, there is an interaction between the one which is used in the TB treatment, which you said rifampicin, will interact with Paxlovid. So when they were earlier explaining, they said the only alternative is remdesivir.
Okay, all right, thank you so much. Okay, so again, thank you for those responses. Let me get to the task. So of course, we do know that TB and COVID, very 2 different diseases. TB has been around since since centuries ago. If you like reading the Bible like me, some people even say that even in the Old Testament, you will find TB there in Leviticus, where I think God promised the Israelites that they would be struck with fever and wasting. So it's a very old disease. COVID, on the other hand, is a new disease. It's going to clock 5 years old, but both diseases have shown that they can cause disease on a global scale. The Global TB report, the last one from 2023, actually put them as the top 2 infectious causes of death. So both are primarily respiratory illnesses, both affect the respiratory system and tend to share quite a few risk factors. So in terms of TB and COVID, so the first question that people ask is, when do we get infections? Is it someone who has TB gets COVID? Is it someone who has COVID gets TB? Or can they get both infections at the same time? So the data that I'm displaying there is from an article in the European Respiratory Journal. There are plenty of other articles, but same setting. So you can get it in all 3 settings. So really there is this overlap between them. Now, this is very well known to everyone that the coming of COVID-19 really set back the gains that were made by the fight against TB. The fight against TB was on an upward trajectory, but modeling studies have actually shown that the coming of COVID-19 has set back the TB fight by up to 8 years. This is due to delayed reporting, misdiagnosis, delayed access to treatment, and of course, there's worsening of outcomes due to those treatment disparities. So there's clearly, the TB program has been affected. Now, let's look at the effect of this overlap on outcomes. So when we get patients with TB and COVID-19 and pull them together before we analyze, we find that the mortality in this group actually approaches 12%. This is in contrast to mortality rates in both TB and COVID-19 that usually go up to 2, maybe maximum 3%. Now, again, quoting the same study that was in the European Respiratory Journal, when you look at factors that are associated with mortality in this age group, so first of all, there's male, gender, then there's, of course, co-infection with diagnosis within a short time of each other. Then there's also not severity of TB, but severity of COVID-19. And when we control for all the other factors, what we did find, and in accordance to, I think, what Dr. Kakusa said, the TB tends to worsen the course of the COVID-19. It's not so much if someone is on a stable course of TB treatment and they get COVID-19, the outcomes are not as bad as if someone with COVID-19 gets TB. So there is that relationship, that is alone. So I hope that point is clear. Now, with this, obviously, as scientists and as practitioners, we want to ask ourselves to say, what are the biological interactions that are occurring? So the first thing is that we know, even from previous viral infections like influenza, like measles, that with a viral infection, you have depletion of cell-mediated immunity, and we know that cell-mediated immunity is primary in the immunity against TB. Now, when we look at TB as an entity, of course, you have parenchymal insult there to the lungs, so you do get a worsening of respiratory distress. So you can see that in some quarters of literature, these two are actually being called the cursed duet, because they do tend to sort of have this bad relationship with each other, where they worsen outcomes. And just to bring it to a clinical level, you can see at certain characteristics that when you look at the clinical picture, both of them have respiratory symptoms, but with TB, we tend to see a more gradual onset, typically weeks to months, though I need to mention that in the HIV population, this is not always the case. TB can present, but for the purposes of this presentation and for the purposes of learning, so TB tends to follow a much more gradual course. Then, of course, another interesting thing is the imaging findings that we have, especially on chest radiography or CT, with ground glass opacities being the main hallmark in COVID-19. And with TB, especially in HIV-negative population, tends to go for the upper lobes or the upper part of the lower lobes, because these are the best aerated areas. So this is just an illustration between the two. You can see there the image on your right that the upper lobe is affected, there's some cavitations there, a bit of bronchiectasis as well. Then you notice the ground glass appearance on the left with the patient with COVID-19. Because of the interface, the Ministry of Health has been rolling out the concept of bidirectional screening, and really the whole question that we ask here is, if a patient has COVID-19, when do we test for TB? If a patient has TB, when do we test for COVID-19? So of course, even in the acute COVID-19 setting, if someone does come in the background of a chronic cough and constitutional symptoms, then you are mandated to test for TB. In the post-acute period, again, if someone is recovering, the cough is reducing, then there's really no need to test. But if we do get worsening of a cough or constitutional symptoms, we can test. For TB, we have two groups of TB patients. We can have new TB patients who we recommend testing for COVID as well because we are in an endemic region, and stable TB patients who we recommend looking at the clinical picture. So if the patient is stable, we can leave them without testing in the interest of conserving resources, but if they do report new or worsening symptoms, then we can test. Now, to answer the main objective of this presentation, which are drug-drug interactions. So this is the drug arsenal that we have in Zambia. So you notice that for COVID-19, as has been alluded to by my preceding presenters, we have treatments for non-severe disease and severe disease, and then we have treatments as well for drug-sensitive and drug-resistant TB. So the major culprits, of course, are nematicravir, ritonavir, and rifampin, because these are metabolized in the cytochrome P450 system. So this is looking at Paxlovid. Of course, the major interactions that we expect are with rifampin, where we see the concentration of nematicravir, ritonavir being reduced by that induction, as has been alluded to. So the strategy that we use in this population is to use an alternative therapy, which is remdesivir in this case, which would be the best alternative. For remdesivir, in theory, it can interact with these cytochrome P450 and cytochrome inducers, but that interaction is mild, so there's really no need to take action. Though, if you notice even from the preceding presentation, remdesivir has been known to cause hepatotoxicity, so there should be that monitoring as well for hepatotoxicity. And with molnupiravir, one of its greatest strengths, despite its mixed results, is that it does not have a lot of significant drug-drug interactions. For severe COVID-19 disease, we'd need to pay attention to dexamethasone. So dexamethasone, again, same interaction, similar to Paxlovid with rifampin, where we see the dosage, we see the plasma levels being reduced. So for dexa, we would consider either upping the dose because it has been shown really to save lives in severe COVID-19. For baricitinib and tocilizumab, no interactions, but I should mention that these two drugs, as has been alluded to, can cause the reactivation of latent TB. So that should be taken into account. So finally, this is like repeating the previous presentation. We have a number of tools because when you look at the drug-drug interactions, it's not feasible for a person to memorize them. So there are certain tools. This slide makes me feel like I've stolen a slide from the previous presenter because he had one exactly like it. So this is a screenshot of the Liverpool drug checker. So this one is free of charge, very easy to use. If you're not sure, you can put a drug on the left, put a drug on the right, it will show you. In this scenario, this was a check between interactions for isoniazid in a person who was on TB preventive therapy and Paxlovid, and you can see that there is clearly green there that there's no interactions. This is another one of my favorite tools. This is the Lexicomp as well. So this, as you can see, is an example being used for the interaction between Paxlovid and rifampin, and you can see clearly there that we are being told to use an alternative therapy. Now, just for those that may not have internet, I'm well aware that there are certain places. This is a tool that we've been using as the Ministry of Health. As we roll it out, we've taken part in just rolling out this tool where we just stick it on the wall, and if someone is not clear about a drug, they can simply look at it and just refer to it. So the take-home message is that, of course, TB and COVID are similar diseases, both are respiratory illnesses, but of course there's that difference in the onset of symptoms. And as Zambia, we are endemic for both infections, so we should consider that co-infection. So for the drug-drug interactions, again, we have a number of tools that we can use to overcome that hurdle. So with that, we will go back to the knowledge checks. I know we're out of time. We'll go back to the knowledge checks. So quickly, 2 volunteers to answer this question, the interaction between TB and COVID. Any hands? I can see Grell and Mwanza there. You can give him the mic, the gentleman in the spectacles there, in the maroon shirt. To your left, ma'am. Yes.
So most likely, am I giving the answer or?
You can choose any option. There's
What's
no...
the question?
Yes, so the question is the interaction between TB and COVID among those options.
The COVID-19 will most likely worsen the TB because there could be some interaction.
Okay, so just to set the correct answer there is actually when you do the pooled analysis, it's actually C. So it's TB that has been shown to really worsen the course of COVID-19. Hence, these patients should be treated. And finally, the best option here for treatment, anyone to attempt? I can see the 2 gentlemen smiling there. Do they want to attempt? Yes.
Would be remdesivir.
Yes, remdesivir is the correct answer. So, Prof, with these remarks, I submit. Thank you for listening.